Hello, hi guys.
So, hi everyone, thank you for joining us for this tutorial. So, today's tutorial is an AFP one and it's on ATE assessment escalation and it's given by Bernard. So, just a few rules. If you're watching via Zoom, just any questions or comments that are covered in the moment, if you just want to pop it into the chat, and any questions that can wait to the end, if you just pop it into the Q&A. If you're watching on the Facebook Live, just comment your questions or comments and I'll pass them on to the tutor. So, that's all from me now and I'll hand it over. Thank you.
Hi, thank you for this. Hi everyone. So my name is Bernard. I'm an F1. I currently work in Thames Valley, so specifically at the Stoke Mandeville Hospital. And today I'm going to be talking about the A2E assessment and escalation. I'm going to be talking about some general stuff, some practical stuff, and really trying to focus the whole discussion about this assessment and escalation sort of in the direction of the AFP and the AFP interview and how you can use it for that. Now, I'm just wondering, should we wait 1 or 2 minutes for more people to join or just get started? All right, I think we can just get started and then people will join as the tutorial progresses. Okay, so first there is a disclaimer, and that's the generic becoming a doctor disclaimer, but I just also wanted to have another disclaimer in that I'm obviously not an ITU consultant, I'm not an anesthetist, but I do have the knowledge that I have. I passed my finals and I do my job every day. So if I don't know something, I'll definitely tell you and you can look it up. But basically, I'll try to give you sort of the practical and what you need to know and how to go about it. All right. So what we're going to talk about today are 5 things, really. The first one is going to be the A2E assessment. We're going to go through a bit of an overview and focus also on what the common omissions are, because I think that's sort of a high yield thing to talk about. The second thing is we're going to talk about is escalation. So when do we escalate? Who is the best person to escalate to? And what to say to them when we do that. And that's very useful for the interview as well as for your everyday life as a foundation doctor very soon. The third thing is we're going to talk a little bit specifically about ITU referrals, because that's something that people often get confused about and do badly or don't know how to do or don't do enough. So we're just going to talk briefly about this. And then we're going to just focus on what is the importance of the A2E in the AFP interview and go through an example case for that as well. So the first thing is the A2E, right? So how to assess and how to communicate your approach, very importantly. So with the A2E, obviously we get taught A2E is the first thing to always think of, but actually there is something before the A2E, and you need to think about a few basic things before you get into the assessment. So first of all, you have to think of your safety. And in these times, safety means PPE. So what PPE do you need? You always need some PPE, but do you need sort of the level 2 or level 1 or level 3 or whatever you need? You just need to decide that and probably communicate it to the person you're speaking with, if it's an OSCE or if it's an interview or if it's a real life situation, you just have to do it. Then when you approach the patient, don't start with assessing their airway, putting your hands on them, just speak to them. You have to discern, are they awake? Are they talking to you? Are they alert? So just speak to them, and that's already going to give you a lot of information. Then look, listen, and feel. If they're not speaking to you, that will be your next port of call. And obviously that's really important, because if they're unconscious and it's a cardiac arrest, you're not going to be doing the A2E, you're just going to start CPR or the equivalent for COVID, right? So safety and PPE, talking to the patient, or look, listen, and feel are very important before you get to your A2E. Now, before you actually start the formal assessment, you can pop the obs on, so pop the SATS probe on, the blood pressure cuff, and get that measuring while you do the rest of your things. And if you communicate that to your interviewer, I think that will be a very practical thing to say, and also will sort of set you apart as somebody who is thinking about how they are actually going to do it rather than just saying something they've memorized. Okay, so now we're moving on to the actual A2E assessment. Now remember what the point of the assessment is. So the point is you assess an element then you address if there is an issue, and then you reassess from the top again, okay? And you always have to keep that in mind. So don't just rattle it off, think about what you're doing. So the first thing is obviously so airway, and for airway, listening is the most important. So first of all, you're listening if there is air moving in and out. If the patient is speaking to you, that's obviously a good sign, but also listen for things like stridor or any noises, anything that might indicate that the airway is obstructed or endangered. Now, if it is, then there are ways of addressing it, right? So in terms of addressing the airway, the first thing to do is always pop oxygen on as much as you can, 15 liters non-rebreathe, always, it's not gonna hurt. Now, in terms of addressing the airway, I'm sure you'll be aware of the escalation pathway. You start with your oropharyngeals, you go to your laryngeal airways, and then you call somebody to put a tube in, right? So that's how you can support the airway, but always remember about the oxygen as well. Now, if you address the airway, for example, you put an oropharyngeal in, then you reassess from the beginning, right? So now airway, let's say, is patent, and you can move on to B. So B is breathing, and here we're looking at look, listen, and feel. So if you've done that, you already know a little bit about breathing. You look at your respirate, you look at your sats, you do your percussion, auscultation, and basically trying to discern how is that person breathing, and are they getting enough oxygen in. How to address it? Obviously with oxygen, and you will know the escalation of oxygen as well. Start with nasal cannulae, you move on to a mask and non-rebreathe or a venturi, and then other more arcane things like high flow oxygen or CPAP, etc. And then obviously if you've done something, reassess from the beginning. Moving on to C, circulation. So here we're thinking of two things. We're thinking of the heart, and we're thinking of the circulating volume, so the fluid. So we're looking at color of the patient, looking at temperature, cap refill, heart rate, blood pressure, JVP, and thinking more specifically of the heart. If we suspect something, maybe do an ECG, maybe do a further assessment of the heart's function. Now here, how we address it, so we either address the fluid part, so we give them fluid or blood, or we address the heart part, and we usually do that with drugs, right? And then we go again and start from the beginning, A, B, and C. Now moving on to D. So D is something that's often missed, but here we're thinking about glucose, we're thinking about pupils, we're thinking about the GCS, and we're thinking about drugs. So basically it's a sort of mixed bag of other things that might really be affecting why the patient is unwell and how unwell they are, that we can address to make them better very quickly. Now, how to address it is obviously very dependent on what the problem is that we found in the beginning. But if we've addressed something, we go back from the top. Now, the last thing is exposure. So here it's very important to expose unwell patients fully. You don't have to expose all of them at once, but it's fine if they're unconscious and it's an emergency. But make sure to look at every part of the patient, looking for bleeding, looking for rashes, looking for anything that you might be missing that might give you a clue as to what's wrong with them. Right? So this is a brief overview of the A2E. I'm sure you have had lots of teaching on that in medical school, but what we're going to talk about more is what to do with this basic assessment and this basic knowledge. Now, before we move on to anything else, let's just focus on some common omissions and what people forget with the A2E assessment. So in airway, what people forget is just because the airway is patent now, it doesn't mean that it's going to be patent forever. So things that endanger the airway and the risk and imminent closure of the airway are very important and very important to keep in mind in A. So stridor, which is the sound of an airway closing or narrowing, is very important to notice and keep in mind. Then the level of consciousness equally. If your GCS classically is 8 or less, your airway is in danger. You lose your reflexes, you lose your ability to protect your airway, and you really have to keep that in mind, okay? So the things that endanger the airway rather than block it are things that people commonly forget. B, so breathing, what people forget is to palpate for the trachea, and that's really important because it gives you a very important clue if it's deviated. Now, another thing that people forget is inadequate ventilation. Just because somebody is breathing, it doesn't mean that they're breathing effectively. If somebody has very, very rapid, very shallow breaths, they'll very likely not be moving very much air. Their volumes will be very low and their sats will be low as well. So keep that in mind. If they're breathing, it's equally with the airway, just because it's patent, that's not enough. With breathing, just because they're breathing, that's not enough. are they breathing adequately? And another thing to keep in mind is breathing. In breathing is COPD. So if somebody is known COPD and is a known CO2 retainer, you might be a little bit more careful with oxygen. But if a patient is acutely unwell, you whack oxygen on them and you don't worry about COPD, because it takes a long time for them to lose their respiratory drive. And that's going to be a problem down the line that you can fix. If somebody is unwell, COPD or no COPD, you put oxygen on them. C, circulation, what people forget is cap refill. Cap refill is very useful, especially if you do a peripheral one and a central one. If they're different, that gives you a clue. Another thing to keep in mind is that the cap refill time can also be reduced. So blood returns quicker to the capillaries than we might expect. And that usually happens in sepsis or CO2 retention when somebody is vasodilated. Another thing to keep in mind in circulation is baseline blood pressure. So think, what kind of a person is that and what age they are in? If it's a 50-year-old man with atherosclerosis, they are 90% likely are going to have a high blood pressure. And then so if their blood pressure is normal, that might actually be very low for them. So keep that in mind. Keep in mind, what blood pressure are you expecting in this person? And if you're not seeing what you're expecting, worry. In terms of circulation, also remember to replace like with like. If somebody lost a lot of blood, give them blood. If somebody lost a lot of fluid because they have been vomiting, give them fluid. Right? If you just pump a person who's lost a lot of blood full of fluid, it's not going to do that much good. In D, always remember glucose. Never forget that. It's so easy to miss. It can have catastrophic effects on GCS and everything else. And you can very easily fix it. Remember drugs, and I said drugs and drugs because remember the recreational drugs that people might have been taking, and also the drugs that we have been giving them. And both of these are very important and very important to consider in D. Now E, what people forget in E is E. So people just don't do exposure and don't expose their patients sufficiently and miss very important clues. And in interviews, they like to put a clue in E, like a rash or a swollen leg, that will really help you with your diagnosis. So don't forget it, okay? Now, the last thing to say about A to E, don't forget common sense, okay? If you can communicate to your interviewer or to your OSCE examiner that you have common sense and you know why you're doing what you're doing, that will make you stand out as a much better and much more competent candidate than everyone else, okay? So in A, what we're looking for is, can they breathe? Are they able to breathe because all the pipes are empty? In B, are they breathing effectively? So are they getting oxygen where they need to get it? C is basically, are they in shock? And by that, as you will know, it means cardiogenic shock or hypovolemic shock, right? So the two types of shock, but C is about trying to identify shock. Now D, are there any hidden problems like glucose or drugs? And E is just an overall check of, are you missing something, all right? So that's your A to E. Now, let's move to a question. And the question is sort of outside of the assessment, really, but it's asking you about the importance and your prioritizing, okay? So which of the following presentations might call for treatment before the A to E assessment, okay? A, history of UTI, fever and rigors. B, history of a road traffic accident, PALE and a low GCS. C, history of a bee sting, swelling and stridor. D, history of central chest pain, nausea, and known angina. Or E, none of the above. Okay, so I'm going to put the poll up. Okay, I'm going to give you sort of 30, 45 seconds to vote. I can see people voting in. I feel a little bit like in a telemarketing studio. All right, so I think everyone who was going to vote has voted. So I'm going to end the poll now. Okay, and share the results with you. Yeah, so just like you guys said, so 50% of you voted for history of bee stings, swelling, and stridor, and that is the correct answer. So what I was getting at here, obviously, is anaphylaxis. So anaphylaxis is one of the very rare exceptions where you wouldn't really go through the A2E assessment straight away. If you recognize that somebody is in anaphylaxis, you whack the adrenaline straight away and you treat before you move on to any A2E, because acting fast is really important. Them having stridor gives us a clue that the airway is in danger. So there's no point doing the whole assessment. We know how to reverse it, and we need to, at least we need to try to reverse it with adrenaline straight away. With all the other all the other scenarios that I mentioned, you would most likely go for the A2E assessment first to know what your treatment priorities are going to be. Okay. So we are going to move on to the second part of the talk, which is talking about escalation and ITU referrals, okay? So if we're not doing so well, or the patient is not doing so well, what can we do about it, and who can we get to help us? And how can we get them to help us as quickly as possible, okay? So in terms of escalating, when should you escalate? The golden rule is, if you are thinking about escalating, you should probably be escalating, okay? Because if you're thinking about it, that means you're worried about the patient, you're worried that you're not might be able to manage them appropriately, so you should probably get somebody to help you. Now, asking for help is always good. Obviously, don't be annoying and ask them to do your job, but if you're doing your job and you're worried about anything, just ask. If they think that it's not worth them coming, if it's not worth them doing something, then they won't. But don't be proud and don't be stubborn. Just ask people for help if you think they might help you, okay? So whenever you feel like you might need anyone, that's when you should be escalating. Now, to whom? And I think here I try to give you a simple guide on who you should be escalating to when different things happen. So there are many different people you can call in hospital. You have your phone, you have your directory, you have your induction app, you can call whoever you want. Now, if you have a question or an issue, or you don't really know what's going on, you can call your SHO, so your F2 or your CT, who might be able to give you a hand. Now, if you are concerned, or your patient is unwell, you should probably calling the registrar, okay? So the registrar is responsible for the patients on a sort of regular basis. The consultant may or may not be in the hospital at any given point, but the registrar is there and they want to know about all the patients who are unwell. So even if you call your SHO to help you out, you need to tell your registrar, because they are the ones who need to know about the patients who are unwell. Okay. For the same reason, if your consultant is available and is around, you can call them if the patient is unwell or you're concerned about them. But I would say even in practice, if there is a registrar, they will be the ones calling the consultant. Now, if your concern is specifically about the airway, so you have a patient with stridor, you have a patient with low GCS, okay, then you should be calling ITU. If you want ITU to review a patient, or you might think that your patient should go to ITU, then you need to be calling ITU, okay? So ITU is a very specific concern with the airway, or you want to send them to ITU. Very similarly, if you're referring somebody to cardiology and somebody has a problem with their heart that you don't understand, or you want them to go to the cardiology ward, you call the cardiologist. So very similarly is the thing with ITU. Okay, now if your patient is very unwell and unstable or deteriorating rapidly, you need to put out a call, okay? You put out a crash call if somebody is in actual cardiac arrest, unresponsive, not breathing, or a peri-arrest call if they're very unstable and deteriorating quickly. The difference between bleeping somebody and putting out a call is that if you put out a call, people come. Nobody is asking you questions, nobody's checking, nobody's thinking about it. If you put out a call, people come. So if you need somebody to come, you literally right now, you put out a call. Okay, so keep that in mind. Now, how to do it? First of all, it's important to pick the right person to escalate. So it might be yourself, but if you're busy with the patient, because for example, you are keeping an airway in, or you are bagging them, or doing something else, putting a line in, get somebody else to do it. Get a different doctor to do it, get a nurse to do it. They're perfectly able to pick up the phone and do it, especially if it's a crash call. Anyone can do that. Okay, if you are giving a handover, so not in a crash call, but if you're referring the patient to somebody, remember about SBAR, situation, background, assessment, recommendation. Okay, have some sort of structure and people will really appreciate that. So that's escalation. Now, the other thing to talk about is ITU referral. So that's the thing that often confuses people and people often sort of get not quite right. So when you are referring a patient to ITU, I would say there are 4 things to keep in mind and tell them. The first thing is, what is wrong with the patient? Obviously, you need to communicate that and you need to have a summary of the issue, or at least as much of a summary as you know. If you don't know what's wrong with the patient, but you know why you are worried about them, then you need to say that. Now, the next thing is telling them why you want ITU involved, okay? And you want ITU involved because you're concerned about the airway, that's one thing, or you want ITU support. And on the next slide, we're gonna see what does ITU have on offer that we might want from them. The third part of your ITU referral is why not ITU, okay? So you need to keep in mind, why might this patient not be a good candidate for ITU? If they're really, really old and frail, if they have a very poor functional baseline, if they have a DNA CPR, if they have a treatment escalation plan in place that says not for ITU, that's a good clue. So none of these things are absolute, but all of them give you a little bit of an indication why they might not be a candidate for ITU at all, or why they might not be a candidate for some of the things that ITU offers. Now, ITU doesn't want you to make that decision, but they want you to make them aware of these factors. So find out how good is your patient normally. Do they walk their dog? Are they not able to leave their room? Are they not able to go upstairs? Do they need help in the bathroom? These are all very important things that will help the ITU decide what to do with this patient. And then lastly, and most importantly, what is your specific question? Do you want advice? Do you want ITU to come and review? Do you want ITU to take them? Do you want ITU to come and secure the airway? You need to tell them, okay? So that's your ITU referral. Now, in terms of what ITU can offer your patient, okay? So in terms of what the ITU can offer your patient, there are 2 things. The first thing they can offer your patient is organ support. And the second thing is ITU nursing. In terms of organ support, you can split it into the A to E assessment, okay? So with Airway, they can help your patient by intubating them or by doing a tracheostomy. And that's how they can put in a definitive airway that's going to be protected from all the different factors that might put it at risk. Now, in terms of breathing, ITU can give non-invasive ventilation, CPAP, high flow nasal oxygen. So these are all oxygen support strategies, or ECMO. So ECMO, I'm not sure how many of you have heard of it. I'm sure some of you have. It's extracorporeal membrane oxygenation, and that's basically a lung bypass. Okay, so they pump blood out, oxygenate it, and pump it back in. So only some centers offer that, but in theory, that's something that ITUs can offer. In terms of circulation, what ITU does is they do anything that's beyond putting fluids or blood in the patient. So any inotropes, any vasopressors, adrenaline, noradrenaline, anything pharmacological that will help the patient's blood pressure is usually done on ITU. They can also offer hemofiltration, which will replace some of your kidney function and, for example, clear potassium if hyperkalemia is a problem. And ECMO can also help with your circulation because it can also be a heart and lung bypass. Okay. Now, D, they can help with hemofiltration, so they can filter all the toxins out that you might need filtrating very rapidly. They can correct electrolyte disturbances, or they can give antidotes that might be risky to give in a normal ward or an ED situation because they have more monitoring. In terms of E, ITU can provide support with skin failure. So if you think that it's organ support, they can support your skin as a failed organ, and they can provide burn care, dressings, fluids, etc. High level of monitoring and high level of support that might be needed for patients who have skin failure due to things like scalded skin syndrome or severe burns, etc. The other side of what ITU provides is nursing. Okay. In ITU, most patients will get a one-to-one nurse, and if you have one-to-one nursing, you can get a much higher level of care, much higher level of monitoring, much higher level of supervision. You can get a very exact fluid balance. You can get very appropriate administration of drugs, very slow administration of drugs with continuous monitoring. And that's another thing that's very importantly provided on ITU. So when you're referring to ITU, keep your factors in mind, right? So what we're doing, what's wrong, why ITU, and here we need to tell them, we think this patient needs organ support. We think this patient needs one-to-one nursing. And then why not ITU? So thinking about the functional baseline and other factors. And then what's your specific question? Okay. Now, here's our second question. So thinking about escalating, you are examining a 6-year-old boy who presented to ED with shortness of breath and a wheeze. He has a known history of asthma, including prior hospital admissions due to this. Initially, he is able to speak in short sentences, but he's not responding to treatment, and you can see that his condition is deteriorating rapidly. He is drowsy, and he can no longer speak now. Which is the best escalation strategy? A, call the SHO. B, call the registrar. C, call ITU. D, put out a peri-arrest call. Or E, put out a cardiac arrest call. Okay, so I'm going to put the question up now. Okay, interesting results. Okay, let's have a few more seconds. Okay, that's very fun. I'm gonna end the poll and then share the results. Okay, so so in terms of the right answer here, I really was going for a peri-arrest call. So let's go through it. Let's go through them in. Now, if somebody picked that, I'm just really interested. If somebody picked call ITU, if you want to put in the chat why you picked call ITU, I'd be really interested to hear. And in the meantime, I'm going to go through the through all the options. So calling the SHO, exactly here, it's not going to help us that much because the patient is really unwell and we're already giving treatment and the treatment is not working. So the SHO might not be able to help us very much. Now, the registrar needs to be aware of this patient and probably in real situation would be aware of this patient. But again, here, as we are already giving the treatment that needs to be given as per guidelines, the registrar might not be able to help as much. Now, call ITU. So yes, you could call it. So you could call ITU and then, but the problem with calling ITU is that when you call ITU, you need to refer the patient to them. So you need to tell them the whole story, you need to tell them what's happening, you need to tell them to come and assess, etc., etc. And that's going to take a lot of time. So if a patient is unstable, as this boy is, and deteriorating quickly, and has now become drowsy, what you really need to do is you need to put out a peri-arrest call because you need people to come immediately. You don't have time to be referring this patient because this patient might stop breathing at any minute. And that's literally what peri-arrest or peri-crash call is. If they might stop breathing at any minute, you need to be putting out a peri-arrest call. But yes, ITU would be people who come in that scenario. But in terms of thinking what's the best thing to do, I think in this scenario would be to put out a peri-arrest call because ITU is going to come immediately rather than speak to you and wait for you to convince them to come. Okay, and cardiac arrest call is obviously not the option here because the patient is not in cardiac arrest yet. Okay, so that is the end of that section. And now I just wanted to speak to you a little bit more about the A2E assessment in the AFP interview specifically, okay? So what to say and how to stay on course. Now, in the AFP interview, the A2E is quite crucial. So as you are probably aware, in your AFP interviews, you usually have 2 interviews. One of them is more research-based, and the other one of them is more clinical. And that's going to be the case all the way throughout your medical academic careers. So whenever you apply for an academic clinical post, there is usually a research panel and then there's a clinical panel, and they just want to make sure that you are a safe clinician as well as a brilliant scientist. Okay, so in the the A2E is going to be a bedrock of any of the answers that you might give in the clinical interview, just like they might be in any OSCE that you would be giving. Now, types of cases in the interview are very different. There are all the emergencies, there are non-emergencies, and there are, so to say, riddles. In terms of emergencies, they can all be found in your cheese and onion at the end, all of your hypokalemias, MIs, etc., etc. So all of your standard emergencies, status epilepticus, that you need to be aware of. You need to be aware of how they present and what the initial treatment might be. Now, in emergencies, A2E is going to be obviously very important, because whenever a patient is unwell, the A2E is the way in which we find out how to help them and what to do. But also, your A2E assessment needs to be mentioned in your non-emergency cases. So even if you get a patient that you see on the ward because maybe they're in pain, etc., you still need to say that you're going to do the A2E assessment, because that's what needs to go through your head every time you see a patient. Now, riddles, so there are, in some interviews and there will be cases which are very complicated and very non-obvious. And the way you get a first crack at them is by doing a very thorough A2E assessment. And there might be some clues, even if it's not obvious, as to what the case might be, or where they want to, where they want you to take it. One example of this is, for example, low GCS. So low GCS has many different causes, but if you really assess the patient A to E, you might find some clues as to what is causing their low GCS, or what are some further investigations and where you need to take it. Now, in terms of a practical approach to this, you're going to need to do a bit of thinking. So you need to decide how much A to E are you going to do for this scenario. If you're seeing a patient in clinic and speaking to them, your A to E is going to be much less important. You can still mention it. In a clinic, you probably mention it very briefly, but obviously if it's going to be an unconscious patient in ED, or a patient that's having difficulty breathing or low SATs, your A2E is going to be much, much more important, and you're going to focus your answer on that. But always keep it in mind, and basically always mention it. But how much you go into it depends on the scenario. Now, remember that there is the pre-A2E, safety, look, listen, and feel, and put the ops on. There is the A2E proper, and there is post A2E, right? Just because you finish the A2E, that's not the end. You need to do some more things, some more investigations. Maybe you need to contact somebody, you need to tell your consultant, etc., right? So the pre, the A2E, and the post are going to be very important. Now, practically in an interview, there two things might happen. So you might be going through your A2E, and they might be giving you information as you go along. So you might say, I'm doing A, I am assessing the airway, I'm listening for if they can speak to me, I'm listening for any added airway sounds, I'm listening for stridor. And they might say, you hear no stridor, or the airway is patent, or they might say nothing. Okay? If they say nothing, you just move on. You assume it's fine, and you move on. Okay? So you just have to feel out what the style of the interviewer is going to be. They might be giving you info as you go along, and they might just leave you to go through the whole assessment. Okay? Now, let's talk about this case. So the case that I put here is a case very similar to one I got in my interview. So here we have a 75-year-old female who presented to ED with shortness of breath. She feels dizzy and faint. She recently sprained her ankle and has been managing this at home with RICE, so rest, ice, compression and elevation, and paracetamol. She's normally active and walks her dog daily. She does, however, have a diagnosis of heart failure, for which she's on appropriate medication. How would you approach this patient? Okay, so in your head, you're thinking pre, A to E, and post, right? So pre, first of all, I would make sure I have the appropriate PPE. I would make sure I speak to her and she is responding to you, and I would put some obs on so that I have that going, right? And then you go into your A, you assess her airway, you do all your listening, her airway is fine. Then you go to your B, you assess her breathing is fine, her SATs are a bit low, so you whack a bit of oxygen, right? Then you reassess, airway, no changes, breathing, SATs have gone up a little bit, but not great, okay? Then you move to C, you look at circulation. So now that you've had your OBS running, you can check what the blood pressure is, you can check what the heart rate is, you can do all your other things, cup refill time, etc., etc. And in this particular lady, you would find that she's hypotensive. Okay, so if she's hypotensive, what are you going to do about it? So you might give her a little bit of fluid. If you found on your assessment no indication that she's fluid overloaded, you might just start with a bit of fluid just in case. To get fluid, you can be practical and say that you need access. So you would get access, put fluid in, and then reassess. So her blood pressure has come up a little bit, again, not great. So at this point, rather than whacking through the rest of your A2E assessment, now we have a person who on B has oxygen that's low with added oxygen, and on circulation has low blood pressure, even though we've started fluids. So we probably need some help, right? So in this scenario, you would call somebody, depending on how they would pitch this case. You could be calling your registrar, or you could be calling ITU, because you have a person who is hypoxic and hypotensive, and what you're doing to her is not helping. So depending on how quickly she's deteriorating, you would either let your senior know or you would let ITU know, right? It doesn't from this sound like she's very unstable and about to go off, so you probably wouldn't put out a call. But obviously you have a little bit of discretion with that. Now, then you would, once you have done that, you would sort of carry on with your assessment, right? So you would check your D, her glucose is fine, no drugs, etc. And then you would expose her, right? And on exposure, they would say you see a swollen pink leg, okay? And that already, if you haven't figured it out yet, it sort of gives you a clue that there might be a DVT going on. And then the DVT has thrown off a PE, and now this lady has a massive PE with cardiovascular instability, and you need to treat her appropriately, and you know how to treat her because you've prepared for your interview and you've gone over your emergencies, okay? And that's your case. Now, throughout this whole chat, they might sit completely silent and give you nothing, or they might be giving you information as you go along. They might say, okay, that's done. They might say, okay, so you've done this, and they said this, or they might just say nothing. And if they say nothing, you can't be discouraged by that. You just have to go on and say what you need to say. Now, the main things to keep in mind is be practical and make it sound like you would actually do the things. So don't just rattle off things that you have memorized. Just actually think, what is the most important, and realistically, what would I do in this scenario? Okay. So now let's do our last question for this session. So this is asking about the patient that we just talked about, so the lady with the PE. So the patient's oxygen requirement has gradually increased, and 15-liter non-rebreathe oxygen is not enough. She has been referred to ITU for further ventilatory support, but which of the following factors, if true, would disqualify her from admission to ITU? Okay. And I'm going to put the question up. Okay. So a lady coming in with a massive PE, however old she was, 75 years old, walks her dog every day. But if any of the things that we see here were true, what could we do? Age, exercise tolerance, heart failure, pre-existing DNA CPR, or none of the above? Okay. All right, so that's been 45 seconds. That's probably enough. So I'm going to end the poll now and share results. Okay, so I am really pleased. So 89% of you got the correct answer, so none of the above, right? So with ITU, there is basically never a completely disqualifying factor from admission to ITU. The only maybe disqualifying factor is if somebody is literally in their last moments of life, or if they're very, very end of life. That might be a complete disqualification from coming to ITU. But in terms of ITU, we always consider what can we offer this patient and what's going to be the outcome. Are we going to have a good outcome, Or are we going to have a very bad outcome? Are we actually going to make their quality of life worse? And none of these things on their own would disqualify her from having treatment and would disqualify her from going to ITU. Now, some of you answered pre-existing DNA CPR. So the only what that means when somebody has a DNA CPR is that literally only that we wouldn't attempt cardiopulmonary resuscitation. Okay, but all the other treatments that we offer in ITU, like the ones we talked about, can still be offered to that patient. Now, it doesn't mean that they would be appropriate. All of them would need to be assessed for what they need, but all of the other ones are still open to that person, and they still need to be assessed separately. Okay, so none of these factors separately or even together would fully disqualify her from coming to ITU. Okay, so I'm really pleased you guys know that. Okay, so the takeaway message from all of this is, what do you need to do? You need to practice your A to E patter. Okay, so your A to E patter is what you say, right? So before I get into my you literally say, before I get into my A to E assessment, so you're signaling to them that A to E is the first thing, but I would make sure I'm wearing the appropriate PPE, I would look, listen, and feel, and I would pop the obs on. Then I go to my A and E. I assess, address, reassess from the top, and then you carry on, right? And just practice saying that without any interruptions, and that is going to make it a lot easier for you to sort of stop when you need to, when you're actually in a scenario. Revise common scenarios, and common scenarios are the common things, so the things in your cheese and onion, the medical emergencies. You really need to know the initial treatment for all of them, and also if you go through them, it will sort of sensitize you to the presentations and the sets of presentations that come up very frequently. Remember to escalate, and remember how to escalate. Always think about who is the right person to escalate to and what's the right thing to do in this particular situation. Now, there is going to always to be a little bit of ambiguity, and obviously calling somebody is better than calling nobody. But the main question you need to ask yourself, do I need somebody to come now, or do I have time to refer this patient to somebody? Okay, that's quite an important distinction. When in doubt, be practical and use common sense. That is literally how you can set yourself apart from the other candidates. There'll be so many candidates who have just memorized a thing and they're going to just rattle it off. Or they're just going to say what they read in a textbook, but actually think, what do I need to do? What's the important thing? Okay. And try to have a bit of a conversation, or say it in a conversational way with the interviewer, and that might actually help. Because rather than being very mechanical, you're saying, well, in A, I'm really looking at, is the Airway patent? So I want to see, is it patent now? And also, is it going to remain patent in the future, et cetera, right? So sort of talk them through your thinking. I mean, it's the same as your medical school interview. You want to show them your thought process and what the way you solve the problem is, rather than necessarily just the answer. Okay, that's quite important, and it just makes them sort of trust you more as a clinician, and that's what they want. They want somebody they can trust as an F1 to do their job safely and efficiently. Okay, so thank you very much. Thank you for showing up on a Monday evening. Now, please do scan this or go to the link for some feedback, and I'm very happy to take any questions. I can't promise I'll answer all of them, but I can at least tell you where the answers are, hopefully. One other thing is, when we're waiting for maybe some questions, is try to practice with your friends. So this is a very easy thing to practice with friends. Your sort of A to E assessment and medical emergencies for their interview. Just get them to give you a scenario and then sit there and listen. And you can just rattle through your assessment and through your A to E and sort of talk through it. They don't even have to say anything, and they don't need to pretend to be an interviewer. They just give you a case, and then you practice saying that to somebody. That's very useful, and it's sort of, you jog your memory on the different medical emergencies, and also practice saying things in a fluid and fluent way. And your friend can give you a little bit of feedback on your body language and communication skills, because that's very easy to get wrong. You can speak too quickly or too slowly or too quietly or too loudly, and it helps to do it with somebody and practice. Okay. Okay, any good resources for this? So I assume that this is the scenarios. I would say there are, so have a browse through the different medical student and junior doctor forums online, because what happens is a lot of deaneries, from what I've heard, reuse the cases that they like. And actually the cases which are mentioned on these sort of discussion groups and stuff might be good for the specific deanery where you're applying to. Definitely speak to people who have applied to your deanery before. So find, I don't know, doctors or foundation doctors or sort of older medical students who have gone through it, because I found, especially in Oxford, that a lot of the cases, if not repeated, are extremely similar. So that can give you a very specific advice on the deanery that you are applying to. But if you know all the emergencies in the cheese and onion, that's enough. That's literally enough. I mean, it would be very, if they're going to give you a case which isn't from the cheese and onion, they will probably expect it to be an unfamiliar presentation, and they will be wanting you to, well, or at least expecting you to approach it as such. And that's not, that's not unusual. You will see patients in the hospital which have a presentation that's not in the cheese and onion, and the interviewers want to make sure that you are able to handle this uncertainty as well. So I think if it's not in the cheese and onion, then don't worry about it. Really, or just go into it with an open mind, and be prepared that some of the cases you see will not be from the cheese and onion, and you need to approach them in a systematic way. And the A2E is just as good for that as anything else. Why do we use, another question is, why do we use glucose for hypoglycemia but dextrose for hyperkalemia? Okay, so glucose and dextrose are the same thing. So dextrose is just like the more scientific word for glucose. So that's not don't worry about that. So if you say glucose or dextrose, it's the same thing. All right, so if any of you who are still hanging around and haven't done the feedback, want to do the feedback, then I shall be most grateful for that. Apparently it takes less than a minute, so that would be great. If there are no further questions, thank you very much for turning up, and good luck with your finals, studying, COVID. Stay safe, stay negative, and good luck with your AFP applications and your interviews.